Well, welcome everyone to this virtual session in the transplant section on endoscopic challenges in the renal transplant patient. I hope that you find this an interesting one as we all face these challenges. So I don't have any disclosures. Our objectives today are to discuss some of the common urologic complications of renal transplant, maybe focusing a little more on ureteral obstruction and on stones. And we're going to talk about some endoscopic strategies for overcoming anatomic challenges in these patients. We're going to spend a little time talking about stones in donors and what are the options there. And finally, I hope that everyone leaves with a bit more confidence in managing these complex patients. Renal transplant, we know it's the best long-term treatment of end-stage renal disease. We know there's an organ shortfall. There were 38,000 transplants in the US in 2019. Yet 68,000 people were on the list. And we are involved with these patients. Up to 50% of the complications that they experience are urologic in nature. And some of them perhaps more acute and dramatic than others. This was a patient I got called to the operating room who, after the kidney was reperfused, was just kind of pouring blood out of the transplant ureter. But we're going to be focusing a little more on endourologic challenges, and so thus the top two, ureteral stricture and kidney stones. So ureteral stricture after renal transplant is the most common cause of obstruction after renal transplant. And these patients are usually asymptomatic because the kidney is denervated. And so they'll often present insidiously, perhaps just simply with sepsis or hydronephrosis or a rising creatinine. It's important to rule out some other causes, perhaps even transient causes like edema or clot. Do they have a lymphocele? Do they have a hematoma that's compressing the ureter? Of course, do they have stones? But distally is the most common site of obstruction, is highlighted here. The most common risk factors are the age of the donor being older, multiple arteries, probably due to that lower pole artery maybe being a bit more tenuous and smaller in general, and we know that supplies the ureter, prolonged ischemia times, and whether or not your transplant surgeons are using stents. And this was discussed at this conference several years ago, but ureteral stents are cost and benefit. They have the benefit of reducing major complications such as leak and strictures, but you are doing that at the cost of a risk of increased urinary tract infections. So traditionally, strictures were treated with decompression and repair, formal repair. But in the modern times, and with the advancements of technique and equipment, we have tried to push the endourologic envelope as far as is reasonable. And whether you do that percutaneously anterograde or retrograde, or like I do simultaneously, or whether you use a balloon or a laser or both, endourologic treatments are generally first line. The European Association of Urology had guideline recommendations for transplant in 2018. And they suggested, as you might expect, if you had a longer stricture or perhaps a stricture that was recurrent after your endourologic attempt, that of course would be a good patient to consider a formal surgical reconstruction. So for these patients, I generally perform what I call an endoscopic evaluation. And it's generally facilitated at first by percutaneous access. What that does is that if you can, here you see this is, you get a nice anterograde nephrostogram, see this just kind of trickle of contrast into the bladder. And what that does is, if you can, facilitate anterograde access, because I will then place a rigid cystoscope, grab the bladder coil of this nephroureteral stent, and externalize it. And so now I have through and through access of the system. And that gives me great flexibility as to whether or not I want to put a ureteroscope anterograde or retrograde, or do I want to use a laser or balloon? It really gives me good access and options. I mainly want to leave the operating room having a full understanding of any reconstructive options that I would want to do in the future, I would need to do in the future. So here I have a cystogram. What's my capacity? What's my gap in between my ureter and the bladder? Is it long, or endourologic attempts going to fail? Do I need to do a Bowari? Do I have enough bladder to do a Bowari? What does my native ureter look like? Am I going to need to swing native ureter around? Is it close? Is it a reasonable capacity? So all this is facilitated by a good endoscopic evaluation. And here you see my anterograde passage of the ureteroscope. But ultimately, I'm going to place a retrograde stent in this patient. And here's dual element access catheter. I'll get a safety wire, and we'll come back to that, the ethos of that in a second. This is what a balloon will look like. You all know this. I use a 4-centimeter balloon. There are various different sizes, but you can see the wasting and then ultimately the expansion. So that's strictures. What about stones? So allograft stones are not common, only less than 2% of transplants. And they can either be gifted with a kidney in situ, or they can be de novo. So in other words, developing in the new transplant. And the de novo causes could either be metabolic or anatomic. I've seen them with a suture into the urinary system, or of course obstruction can play a role. And infection, could it be a urease splitting organism in the system? In terms of management options, you have the full gamut of options for treating stones in the transplant patient. And we'll just go through each of them and some of the considerations in the transplant patient. So for shockwave lithotripsy, it's doable, but remember the kidney is shielded posteriorly by the iliac bone. So you need to shock them either prone or with the bellows. If you have a machine that can shock anteriorly, then that would be a reasonable option. But realize that you're leaving the patient with debris that needs to pass in a solitary system. And that can be precarious. So they need close follow-up, and you might even consider leaving a stent. Success rates are quite reasonable at 66%, enough so that that same guideline statement in the European guidelines of SWAL being first-line treatment in stones that are 1.5 centimeters or less. Now, I will say in looking through that guideline statement, it's based on literature that's a bit older, some older series that includes patients in the 80s. And so more modern data would suggest that certainly endourologic techniques like ureteroscopy, anterograde or retrograde, would be a very reasonable approach. So asterisks on that first-line recommendation. Speaking of ureteroscopy, nice systematic review is the most robust series, kind of collection of data that I could find. And I'll sum this slide up just by saying that the complication rate at 13% was very reasonable, and the stone-free rate was favorable compared to shockwave lithotripsy, with some caveats about the quality of the studies looked at in the series. But I think the point is, as a proof of concept, ureteroscopy is a very reasonable option in the transplant patient, but it's not easy. There are challenges, and I think all of us have experienced the challenge of retrograde access to certain ureteral orifices in transplant patients that are just in these impossible angles. Or the ureters can be quite short, so even if you are able to keep a wire, get a wire up, by the time you start passing things, the wire flops out. So how do we manage that? Let me give you some tips. Some of these from the literature, some of these from my toolbox. Use both a 30 and a 70 in these patients if you can't get the angle right with the 30. And maybe even use a flexible scope. I've certainly had a lot of success both with the flexible cystoscope or ureteroscope. Liberally use your Alvaran bridge and your angled catheters and your angled wires. These are all going to help you to kind of make those impossible turns. Please avoid bowing of the wire in the bladder. That means redundant wire in the bladder, because the minute you start doing that, if you try to kind of back it up and straighten up the wire, you're going to lose access to that short ureter. So I'm always harping on the residents to get that scope right up to the orifice, and don't push if you're meeting resistance, because the minute you start bowing, that game is it's going to start to end. And I liberally use safety wires. So I was alluding to before, even though I was just about to place a stent, I'm going to put a second wire up because it's so easy to lose access to these systems. So this is a transplant allograft in the left lower quadrant with some hydra. And you can watch the hydra ureter down to the level of a pretty good sized stones patient I was called about a few years ago. So I attempted this patient retrograde, and you can see the angle was just sort of impossible. But with my flexible scope, I was able to get a wire kind of up there and ultimately kind of flop the wire up there enough that I was able to get a ureteroscope up to the stone, but I just couldn't navigate the angles. So retrograde just was no good. That's okay. You can manage the stone anterograde. You get access into the kidney. You can see that I had stented the patient and came back in a different setting, access the kidney and go anterograde, and it'll work out just fine. Interventional radiology does that for me for my transplant kidneys. As many know who know me, I get all my own access in the native kidneys, but for the transplant patients, I prefer to have the interventional radiologist do it. That's just me. So speaking of percutaneous management, I do think that that kidney and that superficial lie does facilitate that. But you have to remember that that kidney is scarred. And so it can be tough to dilate, and you also can be precarious to torque. So that rather than being pliable, you can tear a little bit easier and cause some pretty significant bleeding. So you need to be careful about that. There may be a role for mini percutaneous nephrolithotomy in these patients because the mobility of the mini is quite impressive. And there are some data suggesting less bleeding with mini versus maxi PCNL, if you will. Observation, totally reasonable for small stones, and I'm talking less than 4 millimeter, and there are data to back that up with pretty reasonable spontaneous passage rates. But you need to monitor the patients, obviously. What about donors? So historically, this was a contraindication if you had a stone, but given the sort of need to increase the donor pool and the fairly significant number of donors who have asymptomatic stones, most transplant centers in the US have begun allowing donors to transplant if they have to donate if they have stones, if they have access to care and they aren't super high risk for recurrence. So that would be, say, bilateral stones or obvious metabolic abnormalities, very young, these sort of things. What are your options if you're a donor and you have a stone? Well, you could treat the stone before donation. That's totally reasonable. You could take the kidney that has the stone and on the back table at the time of transplant, perform ex vivo ureteroscopy. We'll discuss that in a minute. You could donate without stone treatment if it's a small stone, and there are data that suggest that if less than 4 millimeters, that can be done pretty safely. And then, of course, you can utilize the non-stone bearing kidney and leave the stone in the donor. Maybe less ideal because the follow-up for donors is probably less rigid and reliable than it is for the recipient. So I tend to not love that option. But ex vivo ureteroscopy is quite a good option. So Stuart Wolf and Gary Farber described that first back in Michigan in the early 2000s, and they had a really good success with it, and it didn't take a lot of time on that back table. That's been our experience as well. And this was a pretty robust systematic review looking at patients who had undergone this procedure, and generally it's quite successful. The stone-free rate can be high and the complication rates can be low. There was a case report of a graft loss during ex vivo ureteroscopy, however. So there are also instances, and I know this has happened to me, where you just can't find the stone. And so one presumes that if it was a small stone that they passed it. And so there's a recommendation that maybe you ought to make sure your CT scan's pretty fresh to the donation. So this is what that looks like. Here's the kidney prepared in the back table. It's in an ice bath. You can see we already have our wire, accessing up in the kidney. Another picture of us kind of getting the ureter prepared to accept the flexible scope. This is our own Richard Link performing, thank you, Rick, performing a recent ex vivo ureteroscopy. You can see that the assistant is holding the kidney in a logical anatomic location, so it makes sense to him as he's looking around. I think that's key, but it can be quite successful. What about the zebras? This was a patient who is sent to me after a pediatric en-bloc transplant. That means both pediatric kidneys on the great vessels were transplanted and into a Wallace-type anastomosis. But this patient leaked, required an open revision, began having infections, and developed a big stone, and actually stones in both kidneys. Have been to multiple urologists, continue to have infections, and referred to me. So what you see here, this is the upper kidney and tucked way down in the pelvis here in an impossible place to access is the lower transplant. You can see that has a big stone in it. The upper transplant has a stone in it as well. This stone has already been shocked a few times, no effect. So this is a digital disposable ureteroscope managing that upper kidney stone. And then this angle to this lower kidney was just impossible. But you can see that this disposable digital scope can kind of take a licking and keep on ticking and do sort of these impossible angles. But despite that, I could not access it. So I stented the patient, and I found a very brave interventional radiologist who somehow was able to find some slither of a window by some bowel here into the kidney. And this is the post-op from percutaneous management. It was all done with a flexible scope. There was no getting a rigid scope into this kidney. But you can see we cleaned that kidney out pretty good. So this is a favorable outcome. This is a patient who was referred to me who early post-op had hydronephrosis and does have a history of outlet obstruction and a small capacity bladder and had a TURP. And so there was some conversation about was this lower tract obstruction versus upper tract. But ultimately, the patient, and this is the post-op CT, and you can see that the stent, it seems like maybe it's not actually in the kidney. IR had gotten percutaneous access, and then wait a second, that ureteral stent seems pretty far away from the kidney. And it becomes pretty clear here during our endoscopic workup when they've given us anterograde access. Here's me doing my typical endoscopic workup, getting my retrograde, planning out my reconstructive options. I'm gonna grab the distal coil of the stent. I'm gonna externalize it and do a cystogram, just like we talked about before. But here, when I get my wires up and I start placing my stent, I don't know how well that reproduces, but there is a full 360 of the ureter in the middle of the ureter between the kidney and the bladder. Maybe you can see it a bit better here. And so these type of stents can just be exceptionally challenging to place, but the key is same principles. Get that rigid scope right up to the orifice to help you with the backing. Don't let any bowing in the bladder. And ultimately you can navigate this so that you can get the stent to make that coil up in the kidney. You can use multi-coil stents if you see something like this to position one of the coils in that location. This was another patient referred to me for a history of hematuria and who had a transplant many years ago. And this was the cross-sectional imaging. You can see this is the left allograft with hydronephrosis and a fairly significant size stone. But if you look, it seems to be associated with what is a stent remnant. That stent seems to be fragmented with a large stone in the bladder. So clearly a challenging situation, stone up in the kidney, retained stent for 13 years, stone in the bladder. So we start by clearing the bladder fragment with cystolithopaxy, get our percutaneous access, and then start a percutaneous nephrolithotomy, get our through and through access to facilitate everything. Dilate, careful with our torque. This is the kidney kind of, end on looking at us, clean it all out. Look, there's still a filling defect. So we need to check that out with our flexible instrumentation, just like you would for a percutaneous case. You can do anterograde ureteroscopy to clear the system. And ultimately, we like to manage these patients with nephro-Us. Of course, in native system, I don't leave percutaneous tubes after PCNLs. But in the transplant patients, I think it makes good sense. So there's just a flavor of some of the more complex cases that can come. So in conclusion, urologic complications are common after renal transplant. And there are a wide variety of endourologic techniques to handle this and a wide variety of maneuvers and effectors to manage these anatomic challenges. I think it's reasonable to allow a donor with a stone to donate if they are appropriately worked up and appropriately selected. And my preferred method of management would be ex vivo ureteroscopy because it's pretty quick and pretty easy to do and pretty safe. And in cases that are just maybe the zebras, consider tagging your endourologist. So thanks for your time and attention, and I look forward to discussing our quite short Q&A session. Thanks so much.